Hello everyone, welcome back to Med Revision. Today we are continuing with nephrotic syndrome, but focusing on specific diseases associated with it. So we have primary and secondary causes. Let's start with primary diseases. The first one is minimal change disease or Nils disease. Second, focal segmental sclerosis. Third, membranous nephropathy. These first three are associated with direct podocyte damage, thus podocytopathy nephropathy. Fourth, we have mesangial nephropathy, which we will discuss in later chapters. Fifth, we have proliferative nephropathy types 1, 2, and 3, which are associated with membranopathy. Keep this diagram in your head as we go through these pathologies. Secondary causes of nephrotic syndrome include diabetic nephropathy, lupus nephropathy, and renal amyloidosis. We will be focusing on these as they are the most common, but there are other causes besides these. So let's start with minimal change disease or Nils disease. It is most common in children and often idiopathic, but has been associated with nonsteroid anti-inflammatory drugs usage, Hodgkin's lymphoma, and bee stings. So why these ones? Because for one, we know that nonsteroidal anti-inflammatory drugs are associated with interstitial nephritis, which could progress to nephrosis. Hodgkin's lymphoma and bee stings are associated with release of cytokines, which go on to damage the podocytes once they deposit on them, and this damage causes effacement or flattening of podocytes. Effacement, flattening of podocytes causes them to lose their negative charge. So when podocytes lose their negative charge, they can no longer repel other negatively charged molecules such as proteins because they too are negatively charged and therefore can't be repelled. Hence why they get filtered into urine causing proteinuria. For a Nils disease, only albumin can pass through the membrane, other proteins such as immunoglobulins cannot, and this is called selective proteinuria. For history and physical examination of Nils disease, take into consideration epidemiology data. These patients are commonly children, but adults can be affected. But those are minority of cases compared to children. So typically we see sudden onset of edema, especially periorbital in children who had a recent immune stimulation, maybe a recent infection or a bee sting. For diagnostics, kidney biopsy is the definitive investigation method. Other histological methods such as microscopy are not helpful. Can you tell me why? I'll give you a second to answer in the comments section. So we don't use light microscopy because it won't show anything. That's why the disease is called Nils or zero disease. We cannot see anything. We cannot see hyalinosis, sclerosis, nor effacement. So that's why we use electron microscopy of the biopsy to visualize the fusion of podocytes, termed effacement of podocytes. For management, as I've already mentioned in the previous video, primary causes of nephrotic syndrome often respond to glucocorticoid, and here there is no exception. Most patients respond with good effect, but there are cases of steroid resistance. Therefore, we often change to other cytotoxic drugs such as methotrexate or other immunomodulators. And that will be it for now, guys. If I left anything behind of high yield, please note it in the comments section. See you in the next lecture.